As a trainee copy editor in scientific publishing company, she has various publications in national and international journals. Her list of achievements extends by receiving 2 awards, working as a project associate and fellowship by the University of Madras. With the gain of experience in scientific paper presentation and excelling in national and international conferences, on behalf of Anatomy Department, KSR IDSR, I welcome you to give your lecture on the topic pharmacotherapy for thyroid diseases. Welcome, ma'am.
Hello. Am I audible?
You are audible, ma'am.
Thank you. Thank you, Mami, for your kind words and for your invitation. I thank Jessica also for inviting me for this vertical integration program. I hope the morning session was very good. Let's continue with the afternoon session. Jessica, can I share the screen?
Yes, ma'am.
I hope it is visible.
Yes, ma'am, you're audible and it's visible. The screen is visible, ma'am. You may continue.
Good afternoon, everyone. So today's topic is about the pharmacotherapy of thyroid disorders or diseases. In the morning, you would have seen about the anatomy, physiology, and physiology of thyroid glands. I hope everyone would have been very versed with the anatomy and physiology of the thyroid glands and thyroid. And today we're going to see about the thyroid diseases. So what are the diseases which attach the thyroid, and what are the treatment for the drugs for the treatment for the thyroid. So to start with, I'll just give a little introduction about this, even though you all know about this. Just to recap of the previous sessions. So thyroid gland is the second largest endocrine gland in the body, and it's a butterfly shape. It's controlled by the hyper. Yes.
Ma'am, we have slight disturbance in your voice.
Yes. What happened?
So echo, we can hear echoing, ma'am. It's not clear, actually.
It's not clear.
Voice is very low. But,
very low. 1 minute.
Very low. Yes, ma'am.
How is it now? Hello? This is audible.
No, ma'am. When you speak, there is another voice is also coming along with your voice. When you start speaking, there is a disturbance along with your voice.
Can you hear me now?
Yes, ma'am. This is good.
This is better?
Yes, ma'am. Better.
So yes. If there is any problem in between, you please let me know. Jessica?
Sure, ma'am. Sure, ma'am. Thank you, ma'am.
So thyroid gland secretes mainly 3 hormones. One is triiodothyronine, which is T3, tetraiodothyronine, which is T4. It's also called as thyroxine, and calcitonin. So for the synthesis of this thyroid hormone, so iodine is very important and is necessary for this T3 and T4 synthesis. So how do we get the iodine, which is needed for the synthesis of the T3 and T4? It is derived from the food or the iodine supplements. So iodine which we take, the total. Yes,
Your slides are not visible, ma'am. Sorry to disturb.
slides are not visible.
Yes, ma'am. Yes, ma'am. Now,
Is it fully visible?
no, it's not fully visible, ma'am. It's on one side.
I'll close this and I'll restart again.
Okay.
How is this now? Is it okay?
Yes, ma'am. Perfect.
Perfect. Okay.
I will continue.
So iodine, how do we get the iodine? It is the total body content of the iodine which is obtained from the food and the water which we intake. So out of this 30 to 50 mg of iodine which is needed is being taken by the body, and out of that one fifth of the iodine is present in the thyroid, and remaining it is present in the other foods. So the sources of iodine is available from certain foods, mainly the seafood, bread, dietary products, iodized salts and dietary supplements, and also as they are available as trace minerals. The recommended minimum intake is 150 microgram per day. So iodized salts and iodide preservatives in flour and the bread, and solution of iodized poppy seed oil is also the source of iodine. Now coming to the synthesis, so there are 6 steps in the synthesis of thyroid hormone. One is iodide trapping, then the trapped iodide is converted to iodine by organification or oxidation. Then it is the next process is thyroglobulin synthesis. The next is coupling and proteolysis of thyroglobulin and secretion of thyroid hormones. So this is the picture which shows the synthesis of the thyroid hormone. So first step is the iodide trapping step. So the iodide which is being present in the food is being trapped by the thyroid gland. There is a symporter which has been available.
Ma'am?
Yes?
The slides are not moving, ma'am. Only it's in the biosynthesis of thyroid hormone slide.
Is now?
No, ma'am.
I don't know what is the reason. Now is it okay? Because I'm able to share this.
Yes, ma'am.
Now it is okay.
I can see that next slide.
So the iodine which is being present in the food, it is being trapped by the thyroid gland by the transport process is there, which is the NIS, which is the sodium iodide symporter. This concentrates this ion, this traps the ion. This is stimulated, the NIS is stimulated by the thyroid stimulating hormone. So the first step is the trapping of the iodide from the food or from the bloodstream, and then it is being taken up into the thyroid gland and it is getting oxidated and iodinated. So the iodide trapped by the follicular cells is carried out across the apical membrane by another transporter, which is called pendrin, and it has been oxidized by the pendrin, and it has been oxidized by the membrane-bound thyroid peroxidase enzymes to iodine. Okay, so I plus there is a iodinium ions or hypoiodous acids and enzyme linked hypoiodinates. So these forms of iodine, they combine with the tyrosyl residues which is present inside the thyroid gland, and it is being converted to MIT and DIT. So MIT is monoiodothyrosin and DIT is diiodothyrosin. So that is the second process, and third one is the coupling process. So coupling process is the pairing of the MIT and DIT. So two molecules of DIT combine to form T4, and one molecule of MIT and one molecule of DIT combine to form T3. So that is the coupling process. And next is the endocytosis. That is storage and then release. The thyroid globulin containing the thyroid cells or the thyroid residues, they are just stored in the thyroid colloid until or till it is taken up back, and then there is a release of this hormone. So it is stored, and when there is a release of this thyroid hormone, it is released by endocytosis. And after the release, it is being peripherally converted to T4, of the T4 to T3. That is, T4 is converted to T3. So you get the T3 hormone, and T3 is further converted to RT3. That is the reverse T3. So this is the pathway or the synthesis of the thyroid hormone. So that's the steps which I had told earlier. So first, the transport of iodine to thyroid gland by the sodium iodide importer. Then iodine is oxidized by thyroidal peroxidase to iodine, and then that is the oxidation or the iodination process. And next is the coupling process, the MIT and DIT process, and then the storage and the release process, and finally the peripheral conversion of T4 and T3. So the T4 and T3 ratio within the thyroid globulin will be in the ratio of 5:1, and most of the T3 circulating in the blood is derived from peripheral metabolism of thyroxine. That is T4. When it gets metabolized, it becomes T3. So that T3 is the circulating in the blood is derived from this peripheral metabolism, and T3 is 3 to 4 times more potent than T4, and the receptor affinity for T3 is also higher than the T4. So the transport of the thyroid hormone, so it binds to the plasma proteins, and it is being also available and free form. So the bonding is 0.3% to 0.8%, and as T4, and T3 is 0.2 to 0.5%. So it is being bound to the plasma protein. If it is being bound to the plasma protein, as we already know that it is not available for action. So plasma protein is like a store. It is stored in the plasma protein. So whenever there is the equilibrium between the bound and the unbound hormone levels come down. So when the free hormones levels come down, the hormones are released from the plasma protein. So there will be always an equilibrium maintained between the free and the bound hormone levels. So the plasma proteins are the thyroxine binding globulin, that is TBG, or thyroxine binding per albumin, that is transthyretin or albumin. So these are the three plasma proteins which is available in the blood. So where the hormones will be binding it. The plasma bound iodine mostly is thyroid hormones, and the normal concentration is 4 to 10 mcg per dl. So the hormone which is being released, it is being bound to the plasma protein, and the metabolism is by inactivation by deiodination or by the glucuronide or sulfate conjugation. So the primary site of the metabolism is liver and salivary glands and kidney, and it is excreted in bile, and it undergoes the enterohepatic circulation. So from the bile, the drug is being reconverted by the microorganism present in the liver. So it gets reabsorbed back into the body, and it will produce the action. So that is the enterohepatic circulation. And finally, it is being excreted in the urine. So the normal values of the T4 is 4.8 to 10.4 mg per dl, and the T3 is 79 to 149 mg per dl, and the free T4 is 0.7 to 1.86 mg per dl, and free T3 is 145 to 348 pg, and the thyroid stimulating hormone levels is, the normal level is 0.4 to 4 micro LU per dl per liter. So that's the normal values. So coming to the negative feedback inhibition of the thyroid, or the regulation of the thyroids on the thyroid gland. So when the hypothalamus releases the thyrotropin releasing hormone, TRH, and this thyrotropin releasing hormone stimulates the anterior pituitary to produce the hormone thyroid stimulating hormone, that is TSH, and this thyroid stimulating hormone stimulates the thyroid gland to produce the hormone T4 and T3. So if there is increased amount of T4 and T3, then there is a negative feedback inhibition. They can inhibit the anterior pituitary pituitary. So there is the negative feedback inhibition. So now coming to the functions of the thyroid hormone. So it is involved in growth, maturation of bones, maturation of skeletal system, maturation of nerves in the central nervous system, regulation of growth hormones, regulation of blood, that is body temperature, generation of heat, metabolic functions like regulate the basic metabolic rate, the BMR. Yes?
Ma'am, again the slides are not moving, ma'am. It's on the second slide itself.
It's on the second slide. I don't know what is the problem. Is it visible now? Jessica?
No, ma'am.
Not visible still.
Yes, ma'am. It's not visible.
Now?
Yes, ma'am. But the same thing last time, only one corner.
One corner is being visible. Oh, I don't know what. Can I log out and 1 minute? How is it now? Is it visible?
No, ma'am.
Jessica, is it visible, Jessica? Jessica, hello?
I can't see the slides, ma'am.
You can't see?
Yes, ma'am. Now only one corner is visible, ma'am.
I don't know what's the problem here. Can I re-log in again? Can I re-log in again? Is it okay?
1 minute.
Ma'am, ma'am, you open the PowerPoint, ma'am, then you...
yeah, I'm doing like that only.
Yes, ma'am.
I'm opening the PowerPoint. But only partially it is visible, right? Is it visible?
Ma'am, நீங்க பேசுங்க ma'am.
Ma'am, try screenshot and you go
Yeah,
directly. Yes, ma'am. Now it is visible, ma'am.
how it is visible?
You just change the slides. Let us check, ma'am.
Okay.
It is moving, ma'am. Now, please.
So I was talking about the functions of the thyroid hormones. So that is the it is involved in growth, maturation of bones, maturation of skeletal system, maturation of nerves in the central nervous system, and regulation of growth hormones, regulation of body temperature, generation of heat, and metabolic functions like regulation of BMR, basic metabolic rate, regulate fat, carbohydrates, and protein metabolism. It is also influence mood and behavior, and also affect the fetal development. So this is the mechanism of action of the thyroid hormone. So the hormone which is being released, it binds with the lipid soluble hormone, diffuses into the cell. It's a receptor. This receptor is a nucleus receptor. Okay, so it binds with the nucleus and it activates the receptor hormone complex, which alters the gene expression. So it is a nuclear receptor. So it binds with the receptor and it gets incorporated the DNA and start producing the mRNA. And newly formed mRNA directs synthesis of specific proteins on ribosomes. So a new protein can alter the cell activity. So this is the how the thyroid hormones functions. Okay, it is increasing the it is involving BMR or in the skeletal functions or the neural functions like that. So this is the mechanism of action of thyroid hormone. So this is the measurement of the normal range of T3, T4, so free T4, free T3, etc. So TSH levels. So now coming to the disease of the thyroid gland. So everyone know that is the hypothyroidism, which is a gland destruction, and hyperthyroidism. So hyperthyroidism, it is under the production of thyroid hormone. So three main conditions against the hypothyroidism is myxedema, criticism, and thyroiditis. And then hyperthyroidism, that is thyroid toxicosis, that's overproduction of thyroid hormone. That's mainly the Graves' disease and thyroid toxicosis. Next is the goiter and the neoplastic process. So these are the disease of the thyroid gland. So the difference between the hypothyroidism and the hyperthyroidism. So hair loss and inability to think clearly. So that is the difference. The goiter, enlargement, then reduced heart rate, heart palpitations, strong fatigue, tremors, sensitivity to cold, dry skin, weight gain, puffiness, memory problems, constipation, irregular menstrual periods, then severe PMS, then the depression, mood swings, joint muscle pains, high cholesterol. So that is about the hypothyroidism. Hyperthyroidism, hair loss, again the bulging eyes, goiter, heart palpitation, tremors, heat intolerance, sleep disturbances, weight loss, shortness of breath, diarrhea, increased appetite, irregular menstrual periods, muscle weakness, sweating, anxiety, depression, and mood swings. So again, this I think we have seen this earlier. I'm sorry. And so hypothyroidism. So this is what is hypothyroidism? That is resulting from the reduced circulating levels of the thyroid hormone. That is mainly the T3 and T4. The TSH will be normal, but the T3, T4 levels will be lesser. So the causes of hypothyroidism. There are two different causes. One is primary cause and secondary cause. So primary cause is the dietary iron deficiency, deficiency, or autoimmune Hashimoto thyroiditis, or drugs. Drugs also can cause hypothyroidism. Drugs like amiodarone, lithium, thiocyanates, phenylbutazone, sulfonylureas, Then iatrogenic physician-induced, that is surgical removal of the thyroid gland or the radiation treatment also can cause hypothyroidism. And congenital hypothyroidism is also possible. That is very rare, 1 in 3,000 to 4,000 percent only it occurs, and infiltrative disorders. So these are the primary causes of hypothyroidism. The secondary causes is the pituitary gland destructions or the isolated T deficiency or by the anti-cancer drug, that is bexarotene treatment or hypothalamic disorder. So these are the causes of hypothyroidism. So as it has been appears in 3 forms: myxedema, cretinism, and thyroiditis. So the myxedema, that is this mainly developing in the adults, the deposition of excess mucoproteins in skins or the forearms, legs, and the feet. The features will be the enlargement thyroid gland, goiter, a lack of interest in the daily household chores, and slowing of physical and mental activity, fatigue, dull look, apathy, overweight, and decreased CO. There is shortness of breath and decreased exercise capacity, and decreased sympathetic activity. There will be constipation, sweating, and then the skin will be dry, thickened, yellow, or the cooled extremities will be there. Edema, puffy face, perorbital swellings will be seen. Then ptosis, that's drooping of the upper eyelids, coarse hair, broadening of the facial features, enlarged tongue, deepening of voice, and calorogenic BMR decreases to 30 to 40%. They are cold intolerant. And bone marrow, so there will be having anemia, that is normocytic, that's normochromic anemia will be seen. And menstrual irregularities, carbohydrate metabolism, low blood sugar levels, lipid metabolism like increased serum cholesterol, total glycerides, phospholipids, and CNS, myxedematous madness, that is sort of psychosis, and knee-jerk reaction time increase, and memory loss. So these are the symptoms of the. Then next is the criticism. So there is hypothyroidism developing in infancy or early childhood due to maternal iron deficiency. So there will be listless, somnolent, apathetic to play, and devoid of the initiatives. That's how the child will be having. The features will be the severe mental retardation. So the IQ will be 25 to 49, and mainly occurs in iodine deficient areas of the world, mainly Himalayas, China, and the Africa. And next is the clinical scenarios that they have the impaired skeletal development, impaired CNS development, inadequate maternal thyroid hormone prior to fetal thyroid gland formation. They are often deaf and mute, dwarfism and stunted growth, thick, coarse, dry skin, a protruded abdomen, enlarged tongue, failure of sexual developments. And the other milestones are the length of the child fails to increase, the intention is delayed sitting up and head holding, delayed walking, delayed closure of the fontanelles, and delayed standing up and speech. So this is this is the picture of the child which is having cretinism. So on the left you could see a euthyroid 6-year-old girl. You could see the normal growth of the 6-year-old girl. The right side you could see the cretinism affected girl. So 17-year-old girl with a height of 100 centimeters, mental retardation, myxedema, and TSH of 288. So this is how the child looks. I mean, the person looks when they have this cretinism. So next is thyroiditis, that is inflammation of the thyroid. So that is the Hashimoto thyroiditis, that is the autoimmune disorder, which is a disorder where the immune system attacks the thyroid, the own tissue. So there will be a gradual thyroid failure due to autoimmune destruction of the thyroid, mainly affects persons of 25 to 65 years, and 10 to 1 female predominance. And major cause is non-endemic goiter in children, and genetic components also play an important role. That's patients with Turner syndrome have higher circulating anti-thyroid antibodies. So that is the cause of the thyroiditis. So now The treatment part, so that is the pharmacology of the treatment, is the hypothyroidism is drug therapy. So the T4 and T3 are available in the market. So we can, it has been, so these are the preparations which has been available. Levothyroxine sodium. So it could be taken as a synthetic source. So adults 1 to 1.5 mcg per kg per day orally initially. So first we start within a small dose, and depending upon the response of the patient, it is being adjusted. So the average dose is 1.6 to 1.8 mcg per kg per day. So that is the pediatric dose is 1 to 1.5 mcg per kg per day. So average is 4 mcg per kg per day. So this is T4. Then we have thyroid. This, the trade name is Armour. So that is 30 mg per oral daily. Increase depending upon the need. And Leotrix, or synthetic combo, this T3 and T4, and it is a combination of T3 and T4, and we have this L-triiodothyronine, which is synthetic T3, 25 mcg per orally daily, or increased to 2.5 to 25 mcg. So all the doses are adjusted depending upon, initially it has been started with the slow doses, and later it has been adjusted depending upon the response of the patient. So T3, and these are the preparations which has been given for the hypothyroidism, T3 and T4 preparations. So the pharmacokinetics of T3 and T4 is that thyroxine is absorbed best in the duodenum and the ileum. The absorption is modified by the intraluminal factors such as food, drugs, gastric acidity, and intestinal flora. The oral bioavailability of current preparations of L-thyroxine is average is 80%. As we know that orally when we give the drugs can undergo first pass metabolism, and the drug is capable of binding with the plasma protein. So the availability for the action is also lesser. So that's the oral bioavailability is varying from each product to the other product. T3 is almost completely absorbed when we compare with the T4. That's 90% is absorbed. T4 and T3 absorption appear not to be affected by mild hypothyroidism, but may be impaired in severe conditions. Mild hypothyroidism, the absorption rate does not alter. It does not. Okay. So these factors are important in switching from oral to the parenteral therapy. So for parenteral use, the intravenous route is preferred for the both hormones. So if the person is not responding for the oral therapy, then we can go, mainly for emergency conditions, we go for the parenteral therapies. So T3 is 4 times potent than T4, shorter half-life, greater risk of cardiotoxicity, and best used for short-term suppression of TSH, and the shelf life of synthetic hormone is about 2 years. So the uses of the thyroid hormone T4, T3 is mainly for criticism, adult hypothyroidism, myox edema coma, non-toxic goiter, thyroid nodules, papillary carcinoma of the thyroid, and for the empirical use. So empirical use is refractory anemias, or menstrual disorders, chronic or non-healing ulcers, or obstinate constipation. So these are the empirical use of the thyroid hormones. Now coming to the toxicity of thyroid hormones, in children there will be restlessness, insomnia, and accelerated bone maturation and growth. And growth may be the sign of the thyroxine toxicity. In adults, increased nervousness, heat intolerance, episodes of palpitation and tachycardia, or unexplained weight loss may be the presenting symptoms. This is the toxicity of the thyroid hormones. A chronic overtreatment with T4, particularly in elderly patients, can increase the risk of atrial fibrillation, and also it can relate to osteoporosis. Hypothyroidism and pregnancy. So in pregnancy, pregnant women with hypothyroidism has to be supplemented with the hormones. So to the daily dose of thyroxine be adequate, because early development of the fetal brain depends on the maternal thyroxine. So in many hypothyroid patients, an increase in the thyroxine dose is needed because it needs for the fetal development. So increase in dose will be given and is required to normalize the serum TSH level during pregnancy because of the elevated maternal tissue binding globulin, that is the plasma proteins. So that is we need to supplement thyroxine during pregnancy also. And congenital hypothyroidism, this prevalence is very rare. 1 in 3,000 to 4,000 newborns have this congenital. So the main cause of this is dysgenesis. So dysgenesis is abnormal organ development during the embryonic growth and development. Okay, so the treatment is supplemental treatment with levothyroxine is essential for the normal central nervous development and prevention of the mental retardation. So that's about the hypothyroidism and the treatment of hypothyroidism. Next is the hyperthyroidism. So the most common is Graves' disease. That's the most common form. Mostly 70 to 80% hyperthyroidism is of Graves' disease. So it's an autoimmune disorder in which the thyroid stimulating antibodies are circulating in the blood. So these binds to the thyroid cell and activate the cell in the same way as the TSH. So the T3 and T4 level increases. So as the T3 and T4 level increases, there's a negative feedback inhibition. They will be inhibiting the thyroid gland, that is the anterior pituitary to decrease in secretion of the thyroid stimulating hormones. So it is 7 times greater in the women, and the peak onset is in 20s and 30s. So now for the treatment of this hyperthyroidism is the anti-thyroid drugs. So these are the drugs which is used to lower the functional capacity of the hyperactive thyroid gland. So, and thyroid toxicosis is due to excess secretion of thyroid hormones. So that is the Graves' disease and the toxic nodular goiter. So these are the two main causes of the thyroid toxicosis. The drugs for the treatment are the anti-thyroid drugs. So anti-thyroid drugs are the Thyromites. So they are the we call them as anti-thyroid drugs. So that is the propylthiouracil, methylthiouracil, methimazole, and carbimazole. So they are the thiamide group, which inhibits the thyroxine synthesis. Then we have anion inhibitors, perchlorate and thiocyanate. So they inhibit the iodine trapping. During the synthesis, we have seen an NIS, sodium iodine transporter, symporter. So that symporter is inhibited by the anion inhibitor. And these drugs, this perchlorate and thiocyanates are not used nowadays, very rarely used because there is increased side effects with these drugs. So we are not using these anionic inhibitors. And the next group of drugs are iodinated contrast media, that is the diatrizate and iodsol. We have the iodides, the potassium iodide and sodium iodides. So they will be inhibiting the hormone release. Then we have the radioactive iodine, so which will be releasing the beta rays and the gamma rays, and it can penetrate inside the tissues and destruct the tissues. And then we have beta blockers, that is propranolol. And apart from that, we have miscellaneous drugs like sulfonamides, phenylbutazone, thiopental sodium, lithium, amiodarone, domacaprol. So these are the miscellaneous drugs which is also used in hyperthyroidism. So coming to the first group of drug, that is the Thyromites, which is an anti-thyroid drug. So the main the drugs which we use is methimazole and propylthiouracil. So this is a major drug used in treatment of mainly thyroid toxicosis. The carbimazole is converted to methimazole in vivo, so it's a prodrug. So the mechanism of action of this anti-thyroid drug is they inhibit the thyroid peroxidase enzyme, so that the iodination process is not taking place, and then the iodide is not converted to iodine. So that process is inhibited by this anti-thyroid drug. And also the second mechanism of action is they inhibit the iodination of tyrosine. So the oxidation and iodination of tyrosine is also inhibited by this drug. And also they inhibit the coupling reaction, the MIT and DIT, so that the thyroid hormone is the combination, the coupling reaction two molecules of DIT and one molecule of MIT and DIT is not combined to form T3 and T4. And apart from this action, they also inhibit the peripheral conversion of T4 to T3. So they have a multiple action. That's why it is called as anti-thyroid drugs. So this is the mechanism of action of the anti-thyroid drugs. So they act on the conversion process, the peroxidase. So that is the they be inhibiting the process like the iodination, oxygenation process, and then they inhibit the coupling process, MIT and DIT process. Also, they interfere with the peripheral conversion of the T4 to T3. So when these processes are inhibited, then thyroid hormone synthesis also will be inhibited. So this is the mechanism how this anti-thyroid drug, the Thyromites, are acting. So the carbimazole is more potent given in a single daily dose, and it is completely absorbed and readily accumulated in the thyroid gland. This is excreted in urine, but very slower than the propylthiouracil. Has some immunosuppressive action also. It is have additionally immunosuppressive action, leading to decrease in the serum TSH receptor antibodies. So the antibody levels will be reduced, so that the hormone T3, T4 levels also will be reduced. Has little effect on conversion of T4 to T3, and it can readily process the placenta. So when we're giving for the pregnant women, we have to be very careful in giving this drug. So the ideal drug of choice for hyperthyroidism in pregnant women is the propylthiouracil, and then it is also excreted in the breast milk. So this is the carbimazole. Next is the propylthiouracil. Dose is 10 times of that of the carbimazole. It is given every 6 to 8 hours. Rapidly absorbed with viability of 50 to 80%. It's excreted in urine within 24 hours and does not have the immunosuppressive effect. It inhibits the peripheral conversion of T4 to T3. Can cross the placenta readily, preferably in pregnancy also, and not excreted in the breast milk. So this is it is preferable in pregnancy. Propylthiouracil. So next is the uses of thiamide derivatives. So already we know that it is being used for the thyrotoxicosis, mainly for the Graves' disease and toxic nodular goiter. So the clinical improvement starts after 1 to 2 weeks. Propylthiouracil 50 to 150 mg TBS thrice daily, followed by 25 to 50 mg BDS for maintenance we have to give. And carbimazole 5 to 15 mg TDS initially, and maintenance dose 2.5 to 10 mg daily in 1 to 2 divided doses. It is being given. So the adverse effects of the Thyromites, it's occurs in 3 to 12% of the treated patients. Most reaction occurs early. So the adverse effect is maculopapular pruritic rashes, sometimes accompanied by fever. So other rare adverse effects are urticarial rashes, vasculitis, hepatic failure, arthralgia, and lupus-like reactions, and cholestatic jaundice, lymphoadenopathy, hyperproteinuria, aplastic anemia, and agranulocytosis. So these are very rare side effects of the thiamide anti-thyroid drugs. So next we go on to the iodide salts and iodide. So iodide salts are the sodium iodide or potassium iodide. So iodide salts inhibit the organification, mainly the iodination of the thyrosin, and inhibit the thyroid hormone release. So it causes thyroid constipation. It inhibits the release of the thyroid hormone. So it's called as thyroid constipation. So these salts also increase the size and vascularity of the hypoplastic thyroid gland. So mainly these iodide salts are given before surgery. So to make the decrease the size of the goiter and decrease the vascularity of the hypoplastic thyroid gland, so that it is very easier for surgical removal of the thyroid glands. So this iodides inhibit the release as well as the synthesis of hormone. The onset of action occurs rapidly within 2 to 7 days. This effect is transient because thyroid gland escapes from thyroid block. So after several weeks of the treatment. So there will be a enhanced reaction of the thyroid, iodide action will be seen after several weeks of the treatment. So iodide salts are mainly used in thyroid storm, that is severe thyroid toxicosis, and also to prepare the patient for surgical resection of the hyperactive thyroid. The usual form of these drugs are glucose iodide. So that is iodine and potassium iodide, and they are mixed in water and it is being taken. So glucose iodide 5% iodide in 10% potassium iodide solution. So 5 to 10 drops per day has to be taken. So, or you can take iodide salts like sodium iodide or potassium iodide, 100 to 300 mg per day. It could be taken. It's available as salts or as solution also. So the adverse effect is acute adverse effect occurs to individuals who are sensitive to iodine. So the manifestations will be like swelling of lips, eyelids, injury of larynx, and there will be fever, joint pain, and petechial hemorrhages. And chronic overdose is iodism. So there is inflammation of the mucous membrane, salivation, sneezing, swelling of eyelids, and GI disturbances. So these are the adverse effects of the iodines. And next one is the iodinated contrast media. They call it EPO8. That is, it suppresses the conversion of T4 to T3 via 5 deiodinase in the liver, kidney, and peripheral tissue. So it has been EPO8 has proved very useful in rapidly reducing T3 concentration in thyroid toxicosis. So mainly we use it in the thyroid storm, the thyroid toxicosis. Next is the radioactive iodine. So radioactive iodine is administered. It is a sodium salt of the iodine 131. It is dissolved in water and taken orally. This emits both the gamma rays as well as the beta rays. It gets this gamma rays and beta rays. They get concentrated by the thyroid. It gets incorporated in the colloid and emits radiation and forms within the follicles and cause destruction of the thyroid tissues. So they can penetrate up to 0.5 to 2 mm per, of the tissue, and thyroid follicle cells are affected within undergoes the kinosis and necrosis followed by fibrosis, and a large dose is being given. So this the use of this radioactive iodine is mainly used in hyperthyroidism due to Graves' disease or toxic nodular goiter. The average therapeutic dose is 3 to 6 millicurie, and response is slow. It starts after 2 weeks and gradually increases, reaching the peak at the 3 months. One disadvantage with this radioactive iodine is that it should not be given to younger women, mainly younger patients, younger women, because they become hypothyroidism. That is one of the side effects. If they become hypothyroidism, then they have to take the drug lifelong. So it has been this radioactive iodine is being indicated for older women and older peoples. So next is the ionic inhibitors. These drugs are not, that is thiocyanate and perchlorate. These drugs are not in use nowadays, very because of the toxicity. But the mechanism is that they inhibit the iodide trapping by the sodium iodide symport and prevents the trapping of the iodide from the by the thyroid glands. So they also inhibit the T4 and T3 synthesis also. So these drugs are not used nowadays. So these are the drugs. Next is the beta blockers. So propanol is used to rapidly alleviate the manifestation of thyroid toxicity. So when during the thyroid toxicosis, there will be palpitation, tremors, nervousness, and sweating. So this propranolol it is due to sympathetic overactivity. So the propanol beta blocker will suppress the sympathetic overactivity like palpitation, tremors, nervousness, and sweating. So in addition to this, they also reduce the peripheral conversion of T4 to T3. Not only it suppresses the sympathetic overactivity, and also it has additionally it reduced the conversion of T4 to T3. So beta blockers are used in hyperthyroidism in following situation, that is, while awaiting response to propyl thiouracil or thimerosal, or along with iodides for pre-operative preparations before subtotal thyroidectomy or during the thyroid toxic crisis. So 1 to 2 mg slow intravenous may be followed by 40 to 80 mg orally every 6 hours. It has been given during the thyrotoxic condition, toxic crisis. So next condition is the thyroid storm. It's a life-threatening syndrome. It's mainly occurs in Graves' diseases, decompensated hyperthyroidism. The symptoms of thyroid storms are the hyperthyroid symptoms, agitation, confusion, delirium, psychosis, and the gastrointestinal symptoms like nausea, vomiting, abdominal pain, tachycardia associated with the congestive cardiac failure, heart failure. So the treatment for thyroid storm, it's an emergency condition. So we have multiple drugs given for the thyroid storm. That is the anti-thyroid drugs, mainly the propyl thiouracil, 200 to 400 PO or nasogastric. We have to give methimazole, 60 to 120 mg per day. Divided doses we are giving per orally. And potassium iodide, 2 to 5 drops per oral. Levels iodine, glucocorticoids also, because these corticosteroids are very powerful drugs. So they block the conversion of T4 to T3 and alleviate all the symptoms caused during the thyroid storm. So mainly the glucocorticoids which we are using are hydrocortisone succinate and dexamethasone. And then we have the beta blockers, esmolol, 500 mcg per kg per minute. So and propranolol also 20 to 8 mg per dose. It is being given. So these are the drugs which are given for the treatment of the thyroid storm. So next is the goiter, which is a diffuse or multinodular goiter, so enlargement of the thyroid gland. So most common manifestation of thyroid disease and most often caused by dietary iodine deficiency. That is because of the dietary deficiency, imbalance of thyroid hormone is there. So there are two types, endemic or sporadic. So endemic goiter, it is 10% affects the less than 10% population, mainly the geographic area deficient in iodine. So they have this endemic goiter. The mainly mountainous areas of the world, Himalayas, Andes, and Alps. So here there will be increased PSH and can result from ingestion of certain goitrogens like cabbage, cauliflower, Brussels sprouts, turnips, cassava, etc., etc. So because they contain the pro-goitrin. These goitrogens have the pro-goitrin, so they activate these anti-thyroid agents. So they will be causing goiter. So they prevent the incorporation of iodine with the tyrosines. So that's the endemic goiter. Next is sporadic goiter. That's less frequent than endemic. Mainly the female preponderance and peak incidence near the puberty. Next one is the multinodular goiter. So that is the recurrent hyperplasia, hypertrophy. All simple non-toxic goiters evolve into multinodular goiters and produce the most extreme thyroid enlargement, often mistaken for neoplasm, and asymmetrically enlarged thyroid. So this is the goiter, and drugs or anti-thyroid drugs are being given for this goiters. So small percent of patients may develop a hyperfunctioning thyroid nodule resulting in toxic multinodular goiter. And Plummer syndrome is example without the dermopathy or ophthalmopathy as in the Graves' disease. So in the Graves' disease, we know the exophthalmos, that is the classic symptom of the Graves' disease. And all goiter may cause most effects like dysphagia, compression of the large vessels, and airway obstructions. So the drug treatment is over. Next, surgical treatment. Just one slide about the surgical. Surgical treatment is reserved for conditions like patient preferences and pregnant women who cannot tolerate the anti-thyroid drugs, or child or adolescents intolerant to anti-thyroid drugs, a larger goiter without compressive symptoms, a severe Graves' ophthalmopathy, or the presence of suspicious nodules. So in these conditions, only surgical treatments are there. Otherwise, if it is possible to treat with the anti-thyroid drugs, it is being treated with the anti-thyroid drugs. Thank you. Hello.
Thank you, ma'am. Students, you may post your comments or any queries if it's there. You just put it in the chat box. I will read it out to ma'am. Okay, ma'am. There are no queries. Thank you so much, ma'am, for accepting our invitation. Actually, ma'am is our own faculty and she's a good teacher. Thank you so much, Tanga ma'am, for giving your sharing your valuable knowledge among us. So, ma'am,
Thank you, Dr. Jessica, for for inviting me for this vertical integration. I thank the anatomy department, the head of the department, as well as the whole anatomy team, and congratulations to the anatomy team for your effective organization of this vertical integration.
Thank you so much, ma'am. Would like to honor you with a certificate. Thank you, ma'am. Thank you for your valuable time and knowledge with us. Thank you so much for joining. For the next session and the last session of the day, I would like to welcome Dr. Kartikesh, one of the best teacher in our institution. I would like to invite Mr. Ramesh to give the speaker introduction.
Good afternoon, Dr. Jessica.
Yes, welcome, sir. Dr. Kartikesh, Professor and Head of the Department of General Pathology, KSR Dental College, Changud. Is one of the best teachers in KSR Dental College. He has completed MBBS from Tanjore Medical College and MD Pathology from the Institute of Basic Medical Science, Ceremony, Chennai. He has 18 years of UG and PG teaching experience. He is well expertised in pathology, slide reporting, cytology, FNAC, bone marrow, clinical pathology, immunology, blood banking, clinical biochemistry. He has published various research papers in international and national level. He is a life member of Indian Academy of Pathologists and Microbiology, life member of Indian Medical Association, former senior research fellow of ICMR. Welcome, sir. Welcome to the session.
Thank you, Dr. Ramesh, for your kind words. Am I audible?
Yes, sir.
Yeah, thank you. Thank you so much, Dr. Ramesh and Dr. Jessica, for your kind words and for introducing me. Just a minute, let me open the PowerPoint presentation. Yes, is this slide,
Yes, sir, it's
is this slide visible?
Yes, sir, visible, sir. You're audible and the slides.
Yes. Good morning to all the students. Good morning to all the attendees who are watching this vertical integration program. At the outset, I would like to thank the organizers for thinking of this program, and this is basically a clinical orientation of the students, so that they will be able to understand what they have studied in anatomy, physiology, biochemistry, and on all other basic subjects, to integrate it into the clinical practice. So that is the whole idea of this integration program, and I honestly and forthcomingly welcome the organizers for taking this initiative so that the students will be benefited. Now, coming to the general aspects and hormones which are being secreted and their pharmacokinetics and things like that, I think this has already been vastly covered by all the other departments. And my previous speaker, Dr. Thangam, has also extensively spoke about the clinical features and such about thyroid. So I'm going to limit my topic to the clinical part of the thyroid disorders. So let me go straight away to all the thyroid disorders. So this slide will tell you that basically a person can be euthyroid in state. Euthyroid means he is having normal function of the thyroid gland, or he or she can express more of thyroid hormone secretion, which is called as hyperthyroidism, or he or she may express or secrete lesser amounts of thyroid hormone, which is called as hypothyroidism. Now, as far as the thyroid is concerned, we have to take two things into consideration. One is the structural alteration, and another is the functional alteration. A person can have an absolutely normal, structurally normal thyroid, but still have a functional hypo or hyper effect. Similarly, a person can have a huge multinodular goiter or a simple euthyroid goiter, and those people can be functionally normal. So when we look at thyroid, we always have to look at two things. One is the structural appearance, and second is the functional ability. So based on this, we are now going to first classify the functional part of the thyroid. So functional part of the thyroid, if it is more, we call it as hyperthyroidism or thyrotoxicosis, where there is overproduction of thyroid hormones. And when there is an underproduction of thyroid hormones, we call it hypothyroidism. Now, these are the two main clinical conditions. And then, of course, there are neoplastic processes. There are some tumors which are benign, which means that they don't cause much harm. A simple removal of those tumors is sufficient. The second part of neoplasm is the malignant neoplasm, where the patient will have various problems, and if it is not treated properly with large resection and neck dissection, they may even progress to metastasis and finally even ultimately death. So this is how we classify thyroid disorders. This is going to be of interest to students especially. What are we going to do to assess thyroid function? The traditional teaching is that you do a T3, T4 TSH. T3 means triiodothyronine, T4 is thyroxine, and TSH is thyroid stimulating hormone. This was traditionally followed. Do a T3, T4 TSH. Thyroid function tests, in short, included T3, T4, and TSH. But we have to understand that it is not the bound hormone which is metabolically active. It is the free hormone which is metabolically active. And also we have to remember that T4 is 10 times more potent than T3. So we have little amounts of T4, free T4, can be very, very small, but the function which is provided by such small amounts of T4 will be 10 times more compared to T3, triiodothyronine. So these days, endocrinologists prefer to measure the free T4 levels, the free T3 levels, and along with that, they prefer to measure the thyroid stimulating hormone level. Isolated T3 alone increase is not going to be significant. So that is the first point which I want to emphasize as far as the laboratory evaluation is concerned. Instead of asking for T3, T4, TSH, you will get more information if you ask for free T3, free T4, and TSH levels. Next is the thyroid stimulating immunoglobulin, which is called as TSI. That is also not much used in a clinical setting. I'm going to limit myself to a clinical practice. This lecture is not about enumerating all the various tests which are available, but rather the tests which are most commonly done. TPO, thyroid peroxidase, is a test which is often requested by clinicians because they want to see whether TPO levels are high. And if TPO levels are high, it means that the thyroid hormone levels will be low. The thyroid hormones are getting destroyed, the cells are getting destroyed, and therefore enough hormones are not being secreted. Similarly, antimicrobial antibody. This is a specific test to measure the T4 levels. Antimicrobial antibodies destroys the secretion of T4. Thyroglobulin is a binding protein that is not very often asked. Just like TSI, we don't ask for serum thyroglobulin levels at a usual setting. Radioiodine uptake and thyroid scanning are all done only for determining papillary carcinomas to see if there's any hot spots, or if the thyroid is under functioning to see if there's any cold spot. So that is also not being used much. And the last in the list is FNA. FNA stands for fine needle aspiration. By fine needle aspiration, what we mean is that we take a normal needle which is used for giving IM injections. Those needles, which are then attached to a 5 ml or a 10 ml syringe along with an FNAC gun, if it is inserted into the thyroid and then aspirated, the material which is obtained is placed on a slide and it is spread, then it is stained with MGG stain, and we now have an idea about what exactly is happening inside the thyroid. So if a patient comes with a nodule in the thyroid, the nodule may be 2 centimeters or it may be 10 centimeters, irrespective of the size. If there is a nodule in the thyroid, and if the physician or clinician suspects that there may be something wrong, what kind of disease process is happening inside, then they ask us to do a fine needle aspiration. And I get this request very often. So this fine needle aspiration will tell me directly about what is happening inside the thyroid. If it is just a plain goiter, if it is thyroiditis, or if there is a benign nodule, or if there is a malignant tumor inside. So these are the various laboratory tests. As students, you must be aware of all these tests. So you ask for free T3, you ask for free T4, ask for TSH levels. If you are suspecting hypothyroidism, ask for an anti-TPO antibody levels or an antimicrobial antibody levels. If there is a structural deformity of the thyroid gland, if there's a nodule in the thyroid gland, you ask for an FNAC, a fine needle aspiration. This will give you immense information about what exactly is happening with the thyroid, whether it is hyperfunctioning or hypofunctioning. Now, this is another important, though often overlooked test result, TSH, the thyroid stimulating hormone. Thyroid stimulating hormone over a value of, some clinicians say over a value of 7, some clinicians say over a value of 8. So if it is more than 7 or 8, it means that the patient is usually having a low amount of activity of the thyroid, even though the T3 level may be normal. So some people will come with normal T3 levels and TSH levels of 8 and above. These patients still have to be given Eltroxin or any other thyroid tablet. TSH is a more important and useful indicator of thyroid function compared to T3 levels. If this is the case, if T3 level is normal and your TSH level is high, then definitely you must ask for a free T3-4 and free T3 and T4 levels. Some of the rare causes which causes high levels of TSH is a TSH secreting pituitary tumor or resistance to the thyroid hormone, or even assay artifact. Of course, we have to repeat the test. That is what it means. And if there is an abnormally low TSH level, abnormally low TSH levels can occur in the first trimester of pregnancy. It can occur after treatment of hyperthyroidism, or it can even occur after some medication. So all these clinical situations we have to be aware of so that we don't overdiagnose or underdiagnose. Now, thyrotoxicosis is a state which is excess of thyroid hormone secretion. And the difference between thyroid toxicosis and hyperthyroidism is when there is an excess of thyroid gland function, it is called as hyperthyroidism. It could be just a mild increase or a moderate increase. But thyroid toxicosis means a severe increase in thyroid hormone levels. So this is the difference between hyperthyroidism and thyroid toxicosis. Always toxic means abnormally high levels, which will cause the patient to undergo some form of extreme symptoms. Whereas hyperthyroidism, if it is just a mild hyperthyroidism, the patient will come with some moderate symptoms. Thyroid toxicosis could be primary, it could be secondary, it could be without hyperthyroidism, or it could be even exogenous. Whereas hypothyroidism, once again, could be primary, secondary, or it could be even peripheral. Now, so these are some of the important causes of thyrotoxicosis. This has already been discussed by the previous speaker, but we will go through it again because these are all the causes, but out of all these causes, I would put my finger first on Graves' disease and toxic multinodular goiter, toxic adenoma. These three, Graves' disease, toxic goiter, and toxic adenoma, are very common in a clinical setting. Of course, there are some functioning thyroid carcinomas which will produce thyrotoxicosis, or the other things like struma ovary. Those are all less important clinical conditions. It is always important for us to remember the first 2 or 3 causes. So you should never forget that if a person comes to you with hyperthyroidism, if a person presents with hyperthyroidism, the first thing you should think of is Graves' disease. And usually in Graves' disease, the thyroid will not be markedly enlarged in size. Sometimes the patient will have just a mild swelling of the thyroid. So it can be easily mistaken. So Graves' disease is the most important cause of thyrotoxicosis, and it usually presents quite innocently, structurally. Of course, the patient will come with bulging eyes, they will come with increased heart rate, they will say loss of weight, palpitations, anxiety, all those conditions, all those things will be there. But unless you think of Graves' disease in your mind, you will attribute all these things to some cardiac activity. We will never suspect that there is a underlying thyroid disease at play. So it is also always very important when a person presents with these kind of symptoms, high heart rate, sweating, loss of weight, anxiety, they are They are always hyperactive. They don't sit in one place. They go here and there. This kind of presentation, always think of hyperthyroidism and in that Graves' disease. Then, of course, multinodular goiter. Usually, in my experience, multinodular goiters are usually euthyroid. They are neither hypothyroid nor hyperthyroid, but they can be toxic also. A toxic adenoma is also not very commonly seen, at least in my clinical practice. But if there is a nodule and if it is hyperfunctioning, that could be the reason for this. Of course, all these three conditions can be diagnosed by a simple FNAC. You do an FNAC, you ask for an FNAC, let the lab report come. If the report comes back saying that it is Graves' disease or multinodular goiter or a toxic adenoma, you are done. You have your diagnosis. Next is how you're going to treat. That's all. These are some of the causes of thyrotoxicosis without hyperthyroidism, and subacute thyroiditis is a self-limiting disease. Mostly when it comes in younger women, it is a self-limiting disease, and by 2 years or 3 years, it spontaneously resolves by itself. And silent thyroiditis is also of the same category. The patient comes to you with thyrotoxicosis, you treat them for some time with anti-hyperthyroid drugs, and then after 2 years, they come back saying that they're perfectly all right. They don't need any more treatment. They don't require treatment anymore. So these are some of the signs and symptoms of thyrotoxicosis. Of course, you all know the difference between signs and symptoms. Symptoms is what the patient tells you. Signs is what you elicit from the patient. So if the patient complains of hyperactivity and you see that the pulse rate is very high, which is called as tachycardia, then hyperactivity is what is told to you by the patient. That is called a symptom. And tachycardia, the one which you elicit, is called a sign. And the alarming part of thyrotoxicosis is that some of the patients can even go for atrial fibrillation. You all know what atrial fibrillation means. It means that the atria is contracting irregularly and at a very fast rate. That is the meaning of the word fibrillation. So fibrillation is always associated with a poor cardiac performance. That can even lead to death. Other symptoms are all listed here. I'm not going to go through this one by one because this also has been covered by the previous speaker. But some of the important symptoms which are often told to us by the patient, number 1 is hyperactivity. Number 3 is heat intolerance, palpitations, fatigue and weakness, weight loss. These are the most common symptoms which are told to us by the patient. And the signs which we normally see, we will be able to elicit tachycardia. We will be able to prove that the patient has tachycardia. The patient will have tremors. You ask the patients to extend both their arms in front of them and keep it at a straight. You will see that automatically the fingers are shaking. That is how you elicit tremor. Goiter may be there, may not be there. Skin is usually moist. That is also quite easy. The minute you touch the patient, you will find that the skin is moist. And exophthalmos, this one is important. Most of these people will come to you with protruding eyeballs. So these, whatever I have listed amongst this group is what we see normally in our clinical practice. Of course, all these things will be seen. See, always you have to remember that one single patient will not present with all these symptoms. And one single patient, you will not be able to elicit all the signs. You go with the majority and you always correlate it clinically. You have these symptoms and these are the signs. About 3 symptoms are there, about 3 signs are there. Okay, fine. You can't expect one patient, patient A, to have starting from hyperactivity to sexual dysfunction. And the same patient A, you can't expect him to have tachycardia to pretibial mixed edema. It's not possible for one patient to show all these things. So that is also one point which I want to stress. because now we are talking clinically, and you must be aware that when you're practicing clinically, it is not always possible to elicit all the symptoms and signs in the same patient. This is also an important slide because we have to do a differential diagnosis. We are now clinicians and we have to diagnose. It could be a thyroid problem, or it may just be a panic attack. It may be a panic attack. Probably the patient saw something or experienced something which was disturbing to him, and now he's having a panic attack. Or he could be a psychotic patient. Mania will also present like this. And look at this cause, pheochromocytoma. Pheochromocytoma is a tumor of the adrenal gland, and this can produce something which is similar because of adrenaline. The effect of adrenaline, it can cause all these symptoms, tremors, palpitations, everything can be because of pheochromocytoma. So just because you saw palpitations and tremors and increased heart rate, that doesn't immediately mean that you have diagnosed thyrotoxicosis. You need a supportory corroboratory evidence from the laboratory. Both biochemical parameters and your FNAC results should suit it. And at the same time, you should keep it in your mind that even hypoglycemia, this hypoglycemia is something which we see right, left, and center. It usually commons with elderly people. They forget that they have taken an oral hypoglycemic agent already, and they repeat the dose. Or they probably inject themselves with more insulin than what is being advised. So that will suddenly lead. Or another common thing is they take the tablets, they take the insulin, everything they put, they forget to eat and go off. And while they are half an hour down the line, when they're traveling in the scooter or something, they suddenly feel giddy, sweating, getting, everything will be there, and they will fall down. So hypoglycemia can mimic thyrotoxicosis. Pheochromocytoma can mimic thyrotoxicosis. So this is also an important point which I want to tell you. Always, you should always keep in your mind that there could be some other cause. This is the meaning of the word differential diagnosis. Yes, if you made a diagnosis, fine, you can start treating it, but also keep in mind that it could just be a panic attack or a psychotic patient who is showing his signs of mania. This has already been discussed in detail by Dr. Tangam. She has told you all the various drugs which are available for the treatment of reducing thyroid hormones or increasing thyroid activity, or to alleviate the co-associated symptoms also. So I'm not going to go into this. We will now go into hypothyroidism. So all this time we were discussing about hyperthyroidism. Now we are going to go into hypothyroidism. Amongst this, we have primary, secondary, and peripheral. So amongst the primary causes, this number one, Hashimoto's disease, is by far the most common, usually seen in 30 to 50 age group people. Most of the people suffering in this age group with Hashimoto's thyroiditis may present with a goiter, may present with a normal thyroid gland, or they may even present with a huge mass. So Hashimoto's thyroiditis is something which is a functional problem. It may be associated with a structural deformity, or it may not be associated with a structural deformity. Regarding the other causes which are listed here, not very common. You don't have to bother your head about all this. Iodine deficiency also, slowly we are seeing a decrease in the number of patients who are suffering iodine deficiency, thanks to all the iodized food products which have been introduced by the government of India. They are trying to incorporate iodine. First, it was incorporated into salt. Now they're trying to give little amounts of iodine into various types of powders. So soon we will have very little of iodine deficiency. The point I want to stress here is, if you are going to think of primary hypothyroidism, this is what should strike your mind first. The others are all there, but we can't keep everything in our mind. We can't remember everything also. So primary hypothyroidism, remember Hashimoto's. What does this Hashimoto's thyroiditis or Goiter's thyroiditis mean? The incidence says that it is more common in women. This is quite a big incidence. Out of every 1,000 people, 4 women are affected, and out of every 1,000 men, 1 is affected. So that's quite a huge incidence. 5 out of every 1,000 is a huge incidence. The risk factors are mainly development of anti-thyroid peroxidase antibodies. That is 90% of the cause is because of the development of this antibody. That is why when we were discussing about the laboratory tests which are done for estimation of thyroid function, I told you that many clinicians ask for anti-TPO antibody level. And if anti-TPO antibody levels are very high, then your diagnosis is made. The diagnosis is obviously Hashimoto's thyroiditis. So 90% of the patients will have anti-TPO antibodies, and that alone is enough for a diagnosis. Average age is not 60, it is much lesser. These days we are seeing thyroid, Hashimoto's thyroiditis even at the age of 35 to 40. And since it's an autoimmune disorder, patient usually will suffer from other autoimmune disorders like rheumatoid arthritis or subacute lupus endocarditis or even Sjogren's syndrome. Congenital hyperthyroidism is once again a prevalent. This is called as cretinism, and we have seen about cretinism once again in the previous topic. So let it not be a repeat of the same thing again and again. Let us move on to the next slide. Coming to secondary hypothyroidism. Why should there be a secondary hypothyroidism? There is a pituitary gland destruction. So when we know that pituitary gland is the one which is going to secrete TSH, and that is the one which is going to stimulate the thyroid to produce its hormones. So if the pituitary gland is going to be destroyed by some process, then enough TSH levels will not be there, and that will cause impaired production of the thyroid hormones. Next, isolated TSH deficiency. Once again, we often see it. The other 2 causes, hypothalamic disorders and bexarotene treatment, are all very rare causes. The first is pituitary gland destruction and isolated TSH deficiency. Both of these are known to cause secondary hypothyroidism. And as the slide itself says, the peripheral hypothyroidism, which is quite rare, and even if it is present, the first thing which you think of should be if there is a familial relation. If a patient comes to you with a familial thyroid, my father was having thyroid, my mother was having thyroid, her father was having a thyroid problem. If this is the history, then you have to think of a peripheral hypothyroidism. Now the symptoms of hypothyroidism, once again, we have a list on the left-hand side and we have a list on the right-hand side, but I'm going to stress on the important ones which we see normally in clinical practice. And one of the most important here is listed as the 6th cause, hair loss. Hair loss has become a huge problem, especially among women. And this hair loss, the first thing you should think of is whether she's suffering from a thyroid problem, hypothyroidism. And secondly, they will have irregular menstrual periods. Irregular menstrual periods, once again, is a very common symptom of hypothyroidism. Dry skin, weakness, tiredness, difficulty in concentration are associated features, but by far the most common symptoms of hypothyroidism is hair loss and irregular menstrual periods. Coming to the signs, how are you going to say that the person is suffering from hypothyroidism? The first thing is bradycardia. It's just exact opposite of hyper. There we had tachycardia, here we are having bradycardia. And the second is also an important finding. They will have dry, coarse skin. The skin will not be normal. Normally the skin will be soft, but these people will have dry, coarse skin. They will also have puffy face, hands and feet. Peripheral edema will be there, and they may even suffer from a carpal tunnel syndrome. These are the most important signs of hypothyroidism. Treatment considerations is not under our purview, so we will skip that. Yes, this is what I want you to all to see. So as far as thyroid is concerned, there are only two things. One is hyperthyroidism, another is hypothyroidism. And in hyperthyroidism, what you're going to see is an increase in the T3 levels and T4 levels. The most common causes of hyperthyroidism is Graves' disease or a hyperfunctional multinodular goiter or a hyperfunctional adenoma of the thyroid. This is your take-home point. You can't remember everything that was spoken today by all the speakers. So your take-home point for today, if I want to put it in a concise manner, what are the things you are going to remember as far as hyperthyroidism is concerned? There will be increase in T3 levels. There will be increase in T4 levels. There will be increase in free T3 level. There will be increase in free T4 level. Next, most common cause for the hyperthyroidism is Graves' disease. 90% of the causes fall under this category. Or the remaining 10% will be either a hyperfunctioning nodule or a hyperfunctioning adenoma. These are the take-home points as far as thyroidism, hyperthyroidism is concerned. Then clinically, we have already discussed, patient will come with sweating, weight loss, skin will be warm, cardiac will be showing increased heart rate, and patient will have overactivity, neuromuscular overactivity, tremors, anxiety, all these things will be there. So these are the clinical features of hyperthyroidism. As far as the eyes are concerned, there will be a staring glass. These patients will not even know that they are glaring like this. It's because the ocula is coming out and it is giving as if the patient is staring at us. So that stare itself should alert you that this patient could probably have a hyperthyroid status. Of course, other things will be there. Hypermotility will be there. Osteoporosis will be there. And thyroid storm, which is marked by abrupt onset of severe hyperthyroidism. All these things will be there, but these are the most common features. You have to remember the thyrotoxicosis is a medical emergency. This is a point I want to stress. Thyrotoxicosis cannot be considered as an OP management. Thyrotoxicosis is a medical emergency for the simple reason that it causes atrial fibrillation. And atrial fibrillation, unless the person is admitted in an ICU and is treated with properly by a cardiac physician, patient will die. So this is a point that I want to stress. If at all you come across a patient who is having thyrotoxicosis, a thyroid storm, then immediately you must advise for an admission in an ICU and treatment so that the arrhythmia can be set right. We've already spoken about the diagnosis. I told you that there will be increase in all the hormone levels, whereas the TSH will be abnormally decreased. The thyroid stimulating hormone will be abnormally decreased. So that is how you diagnose hyperthyroidism. And this is called as pretibial myxedema. Tibia is the bone which is seen in your leg. So if you look at this picture, you will see the pretibial myxedema as well as the increased skin pigmentation. Can you see the patch on the right leg? On the left leg, you can see hyperpigmentation, which is associated with pretibial myxedema. Not only that, the patient will say there is itching there. So pigmentation, itching, pretibial myxedema in the legs. Once again, think of hyperthyroidism. Coming to hypothyroidism, we know that because of decreased secretion of the hormones, and it could be because of Hashimoto's thyroiditis, which is the most common cause of hypothyroidism, or it could be due to secondary causes and things like that. Next. all these causes which have already been covered. And look at this first line. That is what I want you to remember. Most are due to Hashimoto's thyroiditis. If you want to study in detail about thyroid, you can read about all the other causes. But the purview of this lecture is just to give you an awareness so that in case you come across a person who is showing some symptom of thyroid, you will be able to diagnose. So that is why I'm limiting my points to a few. Those few points you should be able to remember easily. Cretinism, we know, is hypothyroidism, which affects children, which causes severe mental retardation. This is a child who has been affected with cretinism, and the child, you can see the wide set eyes. That is a giveaway. Something like your Down syndrome, wide set eyes, poor mental IQ status, and mental retardation. There is another disease called as Gall's disease, which is associated with mixed edema. Mixed edema is a type of hyperthyroidism developing in older people. There will be slowing of the physical and mental activity. They will say they get weak very easily. They get tired and fatigued very easily. So this is mixed edema. Mixed edema occurs usually in adults over the age of 50. So that is when mixed edema occurs. It is cretinism occurs in childhood. Mixed edema occurs in elderly age group. That is how you have to remember. Both are hypothyroid conditions. This is a person who is suffering from mixed edema, an elderly person. You can see that the face is chubby, and they will be very lethargic in their attitude. They will walk, they will get up slowly, they will walk slowly, and their whole activity will be very, very slow. And this is the leg which has been affected with mixed edema. You can see that the skin is completely dry, it has thickened and become coarse, and it has also become, the legs have become larger in size. So this is mixed edema. This is mixed edema, which is seen in elderly age group people. Thyroiditis, I told you the most common type of thyroiditis is Hashimoto's thyroiditis, which is also called as lymphocytic thyroiditis. That is the most important cause of hypothyroidism. Incidence is usually between 40 to 65 years of age. And look at the female predominance. This is really huge. So this you can safely say that Hashimoto's thyroiditis affects women 10 times more compared to men. Hashimoto's thyroiditis is a disease which is predominantly seen in women. And the point to remember is that Hashimoto's thyroiditis may not present with a goiter. A goiter by definition means a swelling of the thyroid. The swelling of the thyroid may not be there at all. The patient may be euthyroid. Thyroid is absolutely normal in structure. But the person is saying they're becoming lethargic, they're becoming slow, they're putting on weight, they're getting pretable mixed edema, there is pruritus, there is itching in their legs. All these symptoms are there, but okay, you think there is a thyroid problem, and you look at the thyroid is absolutely normal by appearance as well as by scan. So how then are you going to see that the person is having Hashimoto's thyroiditis? The only way to diagnose this is by FNAC. You do an FNAC of a thyroid, you will get the report. And there you have made your diagnosis. Now, this is another type of thyroiditis, which is also not very common as Hashimoto's, but you have to be aware of this condition, which is called as dequevance thyroiditis. It is a granulomatous form of thyroiditis, which means that there is hyperactivity and overactivity of the thyroid gland, which is result in the accumulation of lymphocytes within it. Those lymphocytes start to even form follicles. So lymphoid follicles within the thyroid gland is called as dequevance thyroiditis. It is less often, less commonly seen than Hashimoto's. The age group is between 30 to 50 years, almost an overlapping age group. And what you have to understand here, look at the fourth point, it is caused by a viral infection. Unlike Hashimoto's, which is an autoimmune disease, this is caused by a virus. and there will always be a history of upper respiratory tract infection. There is yet another type of thyroiditis, which is called as Riedel's thyroiditis. In Riedel's thyroiditis, what happens to the gland is the gland gets completely fibrous. There are fibrous bands running here and there. Finally, the thyroid itself becomes a stone-like. We call it a stone-like. What do you say? A stone-like on palpation consistency. A stone-like consistency to the thyroid gland. If you feel the thyroid gland, if you palpate the thyroid gland, and you feel that it is hard like a stone, the first diagnosis which should run to your mind is Riedel's thyroiditis, because that is the one which causes a stone-like hardening of the thyroid gland. Graves' disease, already we have seen enough about Graves' disease. What you have to remember about Graves' disease is that it usually causes a diffuse enlargement. Diffuse means you have the right lobe, you have the left lobe, and the isthmus. Graves' disease will produce a diffuse enlargement. The right lobe is enlarged, the left lobe is enlarged, the isthmus is also enlarged. Whereas in multinodular goiter, the picture will not be like that. One side, the right lobe will be more enlarged compared to the left lobe, or the left lobe will be more enlarged compared to the right lobe. That kind of picture is called as multinodular goiter. Diffuse enlargement, there's just a whole big swelling here, which will not be very big also. It will be just a mild diffuse enlargement. That is typical of Graves' disease, easily diagnosable by FMAC. We have seen enough about thyrotoxicosis, so we're not going to go into that again. This is thyrotoxicosis. This is called as proptosis. Proptosis means the eyeballs are coming out of the sockets. There's so much of tissue, connective tissue, which is gathering behind, which pushes the eyeballs outwards, causing proptosis. And this is a sign of hyperthyroidism or even thyrotoxicosis. This person obviously is having thyrotoxicosis. This person has to be treated immediately. And now look, there is another picture which shows thyrotoxicosis. So this is not because the eyelids are getting retracted. It is because the connective tissue which is accumulating there is pushing the eyeball outward, causing a stare. This person is not staring at all. This person is just normally looking at us. But to us, it looks like a stare. Now, what is the meaning of the word goiter? We have been discussing everything, so many things we have been discussing. Goiter. Goiter is a general term. If the thyroid gland is enlarged in size, it means it's a goiter. As simple as that. Enlarged thyroid is called a goiter. It could be a multinodular goiter, or it could be a diffuse goiter, or it could be just an adenomatous goiter. Just one swelling in the thyroid gland is called an adenomatous goiter. Multiple swellings in the thyroid gland, multiple nodules in the thyroid gland is called as multinodular goiter. Or if it is diffusely enlarged, it's called a diffuse goiter. So goiter is only a finding. It is not a diagnosis. Some people say diagnosis goiter, multinodular goiter, a diffuse goiter. That is not a diagnosis at all. A diagnosis means you should be able to understand what has happened to the gland. The patient tells you that he is presenting with a goiter. The patient is coming to you with a goiter. So that word goiter as a diagnosis is never acceptable as per medical terms. Goiter is simply a finding which the patient is telling you. The patient tells you in Tamil, you are going to write it in English. So goiter is not a diagnosis. It is simply a finding. What you have to do is find the cause of the goiter, why there is goiter, and then that cause will be the diagnosis. So you have diffuse toxic goiters, non-toxic goiters. Here I have to stress that a structurally deformed thyroid gland, once again I've told this before, I'm going to stress it again, a structurally deformed thyroid gland need not be functionally abnormal. A structurally deformed thyroid gland may be absolutely functionally normal. Similarly, an absolutely normal structure, an absolutely structurally normal thyroid gland need not be functionally normal. The thyroid gland may be normal in structure, but it will be producing excess amounts of T3 and T4 or lower amounts of T3 and T4. So these two are two things which should not be confused. Structurally abnormal thyroid gland, definitely you should have some hyperthyroidism or hypothyroidism. No. Structurally deformed thyroid gland, but normal thyroid function level. That is equally possible. In here, you have this the thyroid follicle, which is like these are the thyroid follicular cells. They are all columnar cells. These are all columnar cells, and they have, you look at the nuclei, they're all round nuclei parallel to each other. This is a typical appearance of a thyroid follicle. And inside the follicle, see, thyroid gland is one of the rare glands. Usually endocrine glands will produce their substance, and they will immediately enter it into the blood. They will secrete it into the blood. Thyroid gland is unique in the sense that it will not only secrete, it has the capacity to store. This is not usually seen with other endocrine glands. Other endocrine glands will make their product, immediately secrete it. Whatever they make, they secrete. Thyroid gland will secrete what is necessary, and it will store what is not yet required by the body. In fact, it has a capacity to store for 90 days. Even if we have lack of thyroid for 90 days, the follicles have the capacity to keep on releasing, because like a camel, it is like a camel. It will store water whenever it is required, then it will take that water. Just like that, a thyroid follicle is like a camel. It will store thyroxine and it will secrete thyroxine as and when necessary for a period of even up to 90 days. After 90 days, still there is no formation of hormones, then only the person will go for hypothyroidism. So this chemical process is something which has already been covered by various other speakers. Let's go to the histological appearance. This is the appearance, whatever we saw in the previous slide was an artist's representation. This is the actual picture under the microscope. So here this large rounded structure is one follicle. Similarly, you have another follicle here. There is a third one here and one at 6 o'clock question. What you have to see is this pinkish substance. It will be pinkish and thick. This is called as colloid. It is the reservoir for your thyroid hormones. This is the place where the hormones are stored and released as and when necessary into the blood. So once again, all this has been spoken about: endemic goiter, sporadic goiter. We know that in certain parts of the world, it is more common. Dr. Tangam already said that in Himalayas, Andes, and Alps, they're all common. And ingestion of certain vegetables like cabbage, cauliflower, Brussels, and sprouts, all these can cause a goiter, and so they are called as goitrogens. And we also saw about sporadic goiter, we saw about multinodular goiter. All these things we've already seen. And I just want to say once more, even though this was said earlier, I want to say about this particular syndrome, this Plummer syndrome. Plummer syndrome is an example which will not have dermopathy or ophthalmopathy. Usually thyroid patients will have some skin problem or an eye problem, either in the form of proptosis or in the form of dry skin or something they will have. This is 90% of my patients will come with either of these symptoms. But this syndrome is a rare syndrome, Plummer syndrome. Even though the patient is having a thyroid deficiency, they will not have dermopathy. Or if they have an excess of thyroid, they will not have any ophthalmopathy. So this is an interesting thing to remember, maybe asked as an MCQ in your NEET exam. And another thing which you have to remember is that there is something called as a mass effect. A mass effect is It's a mass, it's a goiter. The thyroid is now enlarged in size, and it is so enlarged that it is pressing upon the neighboring structures and causing certain symptoms. For example, if it presses against the esophagus, you know that the esophagus is right behind the thyroid. So if it presses against the esophagus, it is going to narrow the lumen of the esophagus. And it is through the esophagus that food is going to go. So if it goes and compresses against the esophagus, then swallowing becomes a difficulty. That is called as dysphagia. Dysphagia means difficulty in swallowing. If it goes and presses upon the trachea, which is also near that, it is going to cause difficulty in breathing. That is called airway obstruction. And all the carotid vessels, internal carotid, external carotid, jugular, all of them are in the neck area, on the sides. So if it becomes so large as to go and compress those vessels, you know that they are the vessels which take the blood to the brain. So if it goes and compresses the vessels of the brain will not get enough amount of oxygen. So thyroid can cause direct symptoms per se, or it can cause pressure effects. So look at this. This is a hugely enlarged thyroid. You can see that the thyroid is vastly enlarged, and not only that, it is also having a retrosternal extension. This is a really huge thyroid. And look at this picture. Oh my God, look at this. Look at this thyroid. Such a big one. It's enlarged so much. And this is the surgical gross appearance, surgical anatomy of the thyroid. You can see that there is one lobe here, there is another lobe here, and this is the isthmus. Both the lobes showing so many nodules. This is the classic appearance of a multinodular goiter. There is a nodule here, so many nodules. More than 10 nodules will be there. And if you cut a bit from this and look at it under the microscope, you will find that there are dilated follicles which are hugely dilated. Dilated means become bigger in size, surrounded by follicles which are smaller in size. So what means that this follicle is compressing upon this follicle and causing a narrowing. So this is a classical histological picture of multinodular goiter. Thyroid neoplasms, I think will be too much already. I've taken 1 hour of your time. I don't want to go into thyroid neoplasms right now. Probably we may keep it for a later date, and because that is a huge topic by itself. Thyroid adenomas and carcinomas will be a huge topic by itself. So today, I just want to limit my talk to hypothyroidism and hyperthyroidism. I hope I was able to convey a few points of interest to you, and I hope you learned something out of this, because whatever I've told you is out of my own experience as a clinician for the past 20 years. So I hope this will also benefit you. I hope this will also benefit you in your practice. Thank you all. Thank you for your patient listening. And once again, I wish to thank the organizers for this lovely program. And once again, I'd like to thank Dr. Jessica, Dr. Rajesh, and Dr. Mukilan for coordinating with me to make this presentation possible. If there are any queries, I'll be happy to answer you. Thank you.
Thank you, sir. Students can post their queries or comments in the chat box provided in the YouTube. If not, sir, thank you so much for your among your busy schedule. You have given us some time, valuable time, as well as you have shared your knowledge with us. Thank you so much for accepting our invitation and presenting a wonderful session to us. Thank you so much, sir. I would like to honor you with a certificate. Kindly accept it, sir.
Okay, madam. I'm pleased to accept the certificate, and I'm also very happy that I was able to be a part of this program. Thank you so much, ma'am.
Thanks a lot for your cooperation, sir. Thank you.
Okay, ma'am. So shall I close the session, ma'am?
Yes, sir. Yes, sir. Thank you.
Okay, thank you.
I would like to call upon Dr. C. Maheshwari, Senior Lecturer, Department of Anatomy, to give vote of thanks.
So, good evening, one and all present here. So, I take this opportunity to thank our chairman, sir, and vice chairman, sir, for allowing us to do the CDE webinar. And I would like to thank our principal, sir, for encouraging us for conducting this webinar. And also, I would like to give my sincere thanks to our webmaster, Dr. Prasad, sir, for the uninterrupted Zoom link and all his technical supports. And I would like to thank all the guest speakers who made the session very interesting. And I would like to thank all the participants who are so patient to listen and cooperate and to make the session with grand success. And finally, I would like to thank Dr. Mugilan sir and Dr. Jessica Mugilan, starting from the beginning, choosing the topic, inviting the speakers, preparing the flyer, and also involving all of us in this program. So thank you, couples. Happy Valentine's Day. I think you would have forgotten. so at least go and enjoy your evening. So thank you both of you. Thank you so much for all. Thank you.
Okay. Well, we are ending the session. Thank you for the cooperation. Thank you.